Let us learn about how do you make the diagnosis of acute pancreatitis. These are my acknowledgements. I'm grateful to my mentor, Dr. Stroline, Mr. Charles Butt, Ms. Angela Deal, and my institution and my mentors. Please read this notice. So you're called in to see this patient. She is a 60-year-old woman, doing well, but this morning started having epigastric pain. She rates it to be severe, uh, 8 or 9 out of 10, and continuous pain radiating to the back for the last several hours, and she has had at least 3 or 4 episodes of vomiting. And this type of story, epigastric pain, severe, radiates to the back, several hours with emesis, you should think about acute pancreatitis. But you also need to keep in mind whenever you have epigastric pain, what are the different organs in the upper abdomen? You can have pain from the stomach and duodenum if there was a peptic ulcer and with penetration to the back. But peptic ulcer pain tends to be periodic, related to meals, etc. The other one is you should think about gallbladder pain, like acute cholecystitis, in which case the pain can be epigastric region, in the epigastric region, but more likely to be in the right upper quadrant and radiates to the right shoulder and along the right side and may have a few vomitings. In an elderly patient in the 60s and 70s, always think about myocardial infarction, especially inferior wall myocardial infarction. So these are the things to keep in mind. If the pain is sudden in onset, you should also think about a perforated gut. But in this patient, the pain developed over a period of several minutes to hours and became severe, and radiation to the back, you think it is pancreatitis. And what else do you need to do to make a diagnosis of pancreatitis? You make sure the patient, look at the vitals to see whether the patient is volume depleted or not. That's a very important thing to keep in mind. And you examine the abdomen. They tend to have some epigastric tenderness, maybe, but not not rigidity. They may have some guarding. The ulcer tends to be sluggish. And you want to, when the patient comes in with this, make sure you take care of the pain, make sure you start IV fluids to hydrate the patient, and then after you've drawn the labs, and in addition to a bunch of labs, you will certainly do amylase and lipase because you're thinking about acute pancreatitis. So when the lab comes back, you look at the labs. Here is amylase, which is 600 units, and you see where it is in terms of the range in that particular hospital. Here it is at least 3 times the upper limit of normal that is required to make a diagnosis of acute pancreatitis along with pain. You have to have at least 2 out of 3 features. Pain, biochemical evidence of pancreatitis on blood work, imaging evidence of pancreatitis on CT scan. So you also look at the lipase. Lipase is also elevated, again 3 times the upper limit of normal. So you think that, hey, patient has pain and elevated amylase and lipase. I don't think there is any other reason for this combination, most likely acute pancreatitis. I will manage the patient for now with pain meds, aggressive IV hydration, and with the ringer lactate. Sometimes you are not sure, and the story is not clear, and in that case, you may ask for a CT scan or MRI so that you can be sure about the diagnosis of pancreatitis. When you do a CT, you always do the CT with contrast. And when you do the contrast CT, as you can see here, you can see the aorta white, superior mesenteric artery white, and you also see the portal vein and the splenic vein. And the pancreas has brightened up. This is normal pancreas with nice lobulation. There is no inflammation. On the other hand, if you look at this one, you have loss of lobulation and some swelling of the pancreas and some inflammation around the head of the pancreas compared to the body and tail. And there is no necrosis. This is interstitial pancreatitis. Interstitial pancreatitis without necrosis, patients recover. And they tend to have short hospital stay. But in addition to inflammation of the pancreas, you also should look at whether there is peripancreatic inflammation. And here there is fluid and inflammation tracking around the pancreas. There is peripancreatic inflammation. So this is still interstitial pancreatitis with peripancreatic inflammation. And if there is ischemic necrosis, then you will see areas of necrosis, and this is necrotizing pancreatitis. Patients with necrotizing pancreatitis tend to take longer to recover, maybe weeks to months in the hospital. They tend to have systemic inflammatory response. They may end up having complications like organ failure. So when you see necrosis, you should be very careful in managing these patients. So let's come back. In order to make a diagnosis of acute pancreatitis, you need 2 out of 3 features. Clinical features of pancreatitis: epigastric pain radiating to the back, lasting for hours with vomitings. Elevated amylase and lipase, more than 3 times the upper limit of normal, not mild elevation, less than 1.5 times, 2 times, doesn't count it, 3 times the upper limit of normal. And imaging evidence of pancreatic inflammation with or without peripancreatic fluid, with or without necrosis. So, in summary, for acute pancreatitis, you need 2 out of these 3 findings: pain suggestive of pancreatitis, pancreatic enzyme elevation in the blood, pancreatic inflammation on imaging studies. I hope this is helpful. Otherwise, you'll be making a lot of wrong diagnosis of acute pancreatitis. If you just have pain, mild elevation, and you don't do CT to document pancreatic inflammation. I hope this is helpful. Thank you.